Um, Imagine going to the doctor with excruciating, burning pelvic pain, and, well, they prescribe an exercise that actually makes it dramatically worse.
Yeah, which is a nightmare scenario for a patient.
Right. I mean, for roughly 16% of women dealing with chronic pelvic floor issues, that is exactly what happens when they are told by a well-meaning clinician to, just do your Kegels.
It happens all the time. And today we're looking at a diagnostic landscape that is entirely invisible to the naked eye.
We really are. We are focusing on this massive medical mystery that affects up to 20% of women at some point in their lives, yet it's so rarely talked about openly.
Right, because of the stigma.
Exactly. We're talking about severe pelvic pain, specifically, pain when trying to use a tampon, or during a routine gynecological exam, or during sex.
And because this pain is invisible, and the anatomy is just incredibly complex down there, patients often bounce from specialist to specialist for years without any real answers.
Which has to be so incredibly frustrating.
Oh, absolutely. They frequently just get this generic advice that completely misses the root cause.
So for this deep dive, our mission is to figure out exactly how modern medicine actually solves this.
We're getting right to the core of it today.
Yeah, we are looking at what specific clinical criteria define a patient as a potential candidate for a major surgical procedure, which is called a vestibulectomy, versus a candidate for conservative, multimodal, down-training physical therapy.
Right, like what are the actual clues that tell a doctor which path to take?
Exactly. And we have a really robust stack of sources to pull from today to answer that for you listening.
We do. We're synthesizing the 2021 European guidelines for vulval conditions, some highly detailed clinical retrospectives on vestibulodynia, and comprehensive treatment protocols from dedicated pelvic pain rehabilitation centers.
Okay, let's unpack this, because knowing how doctors decide between two radically different treatments for invisible pain is just, well, it's fascinating.
It really is.
And it is entirely relevant to you, to anyone listening who cares about the mechanics of the human body, because the human body is a system, right?
Absolutely a system.
And sometimes you just have to figure out if the problem is in the software or if it's in the hardware.
I love that. The software versus hardware framework is really the perfect way to look at this.
Yeah.
Yeah, because we are exploring a true diagnostic crossroads here. On one side, you have muscle tension, which is the software glitch, and on the other side, you have overgrown pain nerves.
Which would be the structural hardware abnormality.
Exactly.
So let's start by looking at that software glitch first. Based on the guidelines, this points to the candidate for down-training physical therapy.
Right.
Now, I have to admit, when I first started reading these clinical protocols, I realized I held a massive misconception about pelvic floor problems.
Well, most people do, honestly.
I always just assumed pelvic floor issues meant weakness. Like, I don't know, the muscles are too loose, leading to incontinence or something like that.
Yeah, we are heavily conditioned to think of pelvic floor dysfunction strictly in terms of low tone. Usually we associate that with childbirth or menopause.
Right, exactly. But for a significant portion of women, the problem is literally the exact opposite. It's a high tone or hypertonic pelvic floor.
Yes. With a hypertonic pelvic floor, the muscles are chronically contracted.
Like they're stuck.
Yeah, they are basically locked in this state of severe spasm or guarding, and they are completely unable to relax.
Okay, let me pause on that because this goes right back to the Kegel issue I mentioned.
It does.
If every general health article out there tells women to do Kegels to strengthen their pelvic floor, but a patient actually has a high-tone pelvic floor, doing Kegels seems like it would just fuel the fire.
Oh, it absolutely fuels the fire.
It's basically like telling someone who has a severe agonizing calf cramp to just, start doing calf raises.
That calf cramp analogy perfectly captures the physiology here. I mean, you are asking an already exhausted, shortened, spasming muscle to contract even further.
Which sounds agonizing.
And it is. The clinical guidelines highlight that Kegel-type exercises will actively exacerbate pelvic floor dysfunction in these specific patients. It drives the muscle into a deeper spasm and just generates more pain.
So, if a patient is sitting in the clinic, what are the specific clinical clues that tell the doctor, okay, we're dealing with a software glitch here?
Right. How do they know this patient is a prime candidate for down-training physical therapy rather than, say, surgery?
Exactly. What are the signs?
Well, the history is the first major clue. A hypertonic pelvic floor doesn't just cause pain with penetration.
Oh, it doesn't.
Because those muscles cradle the bladder and the bowel, chronic spasm affects those systems too.
Okay, that makes sense.
A classic presentation actually includes urinary urgency or frequency. In fact, This often gets misdiagnosed as interstitial cystitis or recurrent urinary tract infections.
Wait, really? Just because the tight muscles are physically pressing on the urethra and bladder, sending false "I need to go" signals to the brain.
Exactly. The mechanism. The tension physically compresses the surrounding anatomy.
Wow.
Yeah, the patient might also suffer from severe constipation, or they might complain of a deep aching pain just from sitting down for long periods of time.
Because they are essentially sitting on a knot of spasming muscle all day.
Right. Another definitive clue in the history is the timeline of the pain itself.
The timeline, like when it started.
Yes, the clinician will ask if the patient has ever had pain-free sex or, pain-free tampon use in the past.
Okay.
If the patient had years of normal function, but the pain started later in life, perhaps after a severe yeast infection, a physical injury, or even a period of intense psychological stress that is classified as secondary vestibulodynia.
Got it. So secondary onset strongly suggests some muscle guarding issue.
Exactly. The software learned a protective reflex and just got stuck.
The history paints a really clear picture then. But the sources also note that the physical exam provides highly visible clues too, right? Even if the pain itself is invisible.
Yes, during the exam, a trained clinician might observe that the vaginal opening actually appears physically small or narrowed.
But the skin hasn't magically shrunk, right?
No, not at all. The underlying musculature is pulling so intensely tight that it restricts the opening physically.
Wow.
And you will also see unconscious behavioral clues, like the patient might involuntarily raise their pelvis right off the examination table.
Just totally flinching.
Yeah, or physically retreating and guarding against the exam before it even really starts.
And the final confirmation is the single-digit exam, right?
Correct. Just one single finger pressing on the pelvic floor muscles internally.
So if that internal touch triggers intense tenderness and recreates the patient's pain, the doctor knows the muscle dysfunction is the primary culprit.
Exactly. That basically confirms the hypertonic diagnosis.
So the treatment for that is down training.
Yes, multimodal down training.
But I kept wondering while reading the rehab protocols, how do you down train a muscle that you can barely even feel?
It's notoriously difficult.
Right, because you can easily flex and relax your bicep because you can see it. But the pelvic floor is largely involuntary and entirely hidden.
Which is why it requires a highly specialized multimodal approach with a dedicated pelvic floor physical therapist.
Okay, so what do they actually do?
One of the most effective tools they use is biofeedback.
Biofeedback, how does that work here?
Well, the therapist places surface electromyography sensors directly on the pelvic area.
Okay.
And these small sensors pick up the electrical activity of the muscles, and they actually display it as a visual graph on a computer screen.
Oh, wow. So you are making the invisible muscle tension entirely visible to the patient.
Exactly. The patient can literally watch their own muscle spasm on the screen in real time.
That is incredible.
It is. The therapist then guides them through specific breathing and relaxation techniques, and the patient watches the graph drop as they do them.
So it visually trains the brain to recognize the physical sensation of a contracted pelvic floor versus a relaxed one.
That's it, exactly. They also utilize vaginal dilators.
Ah, right. But the sources are careful to point out these aren't used to physically stretch the vagina, right? Because the tissue itself is already elastic enough.
Correct. The dilators actually serve a dual purpose.
Yeah.
Physiologically, they help restore tissue compliance,
Meaning?
meaning the ability of the muscle to yield to pressure without immediately going into a protective spasm.
Ah, okay. And the other purpose.
Psychologically, they help the brain unlearn the fear of penetration.
That makes total sense.
The patient works through progressively larger sizes in a very safe, controlled environment. They are basically proving to their own nervous system that penetration does not equal pain.
But probably the most surprising technique I saw, which was mentioned in the New York City Pelvic Pain Guide, was pelvic floor dry needling.
Yes, dry needling.
Inserting needles into the pelvic floor muscles just sounds incredibly daunting.
It definitely sounds intimidating. But it addresses these stubborn myofascial trigger points that manual massage just can't always release.
What exactly is a trigger point in this context?
Well, a trigger point is a hyper-irritable spot in a really tight band of muscle. So the physical therapist targets deep pelvic muscles, like the obturator internus or the levator ani. And when the needle hits the trigger point perfectly, it creates a localized twitch response.
A twitch response? What does a twitch response actually do?
It basically causes a rapid, involuntary contraction of the muscle, which is followed immediately by a total release.
Oh, interesting.
Yeah, it momentarily depletes the muscle's localized energy reserves, and it interrupts the dysfunctional nerve signals that are keeping it locked in that spasm.
So it physically resets the neurological tone of that muscle band.
Exactly. It's a hard reset for the muscle.
Okay, so you reset the software, you use the biofeedback, the dilators, and the needling. The muscle finally relaxes, the single-digit exam shows no more tenderness, and for many women, the pain completely resolves, right?
Yes, for the down-training candidates, that is the goal.
But here's where it gets really interesting. What happens if the physical therapist gets the muscle completely relaxed, so the software is fixed, but the patient is still experiencing agonizing pain?
Ah, yes. That is the pivotal diagnostic crossroads we mentioned.
Okay, break that down for us.
When the muscle is relaxed, but the pain completely persists, we move from a software glitch to a hardware problem.
Meaning the pain isn't originating from a tense muscle beneath the skin anymore?
Exactly. The pain is originating from the skin itself.
Specifically, the vestibule, right? The tissue right at the vaginal opening.
Right. In the medical literature, this is known as localized provoked vulvodynia, or LPV.
And more specifically, neuroproliferative associated vestibulodynia.
Yes, that is the exact term.
Let's parse that. Neuroproliferative. So neuro meaning nerves and proliferative meaning rapid growth or multiplication.
Exactly. When researchers take biopsies of the vestibular tissue from these specific patients, they find a biological anomaly.
They don't just find normal skin.
No, they find chronic inflammation, usually involving an abnormal concentration of mast cells, and they find a physically higher density of pain nerve fibers.
Wow. So the nerve endings have literally overgrown and multiplied in that one specific area.
Exactly. It's a structural change.
The analogy that came to my mind while I was reading this is, well, it's like a severe sunburn.
Oh, that's a great way to put it.
Yeah, because normally stepping into a warm shower feels great, the water isn't harmful, but if you have a blistering sunburn, that exact same warm water feels like a blowtorch.
Exactly.
The stimulus hasn't changed at all, but the nerve endings in your skin are inflamed and hypersensitive, so they entirely misinterpret a normal, gentle touch as severe tissue damage.
That sunburn analogy perfectly illustrates hyperalgesia.
Hyperalgesia, meaning?
It is an extreme pain response to a completely non-painful stimulus.
Yeah.
And in neuroproliferative vestibulodynia, this is a structural, microscopic abnormality.
Right.
Because it's a hardware issue, no amount of physical therapy or biofeedback or deep breathing is ever going to make those extra nerve fibers just disappear.
Because they're physically wired into the tissue.
Yes. And this is the patient who becomes a candidate for surgery, specifically a vestibulectomy.
No. Deciding to cut out tissue from such a highly sensitive area is a massive clinical decision.
It's a huge step.
How does a doctor definitively prove a patient is actually a surgical candidate? Like, what are the specific criteria?
Well, the first major criterion contrasts sharply with the physical therapy candidate we just talked about. The surgical candidate usually presents with primary provoked vestibulodynia.
Oh, primary. Meaning they have never, at any point in their life, had pain-free penetration.
Exactly. The timeline is critical here. It is hurt since the very first attempt at using a tampon, their first ever gynecological exam, or their first sexual experience.
So the nerve overgrowth has just always been there.
Right, possibly as a congenital issue or an early localized inflammatory response.
Okay, then there is the physical test. Every single source we reviewed pointed to the Q-tip test as the gold standard for diagnosing this.
Yes, the Q-tip test is vital.
Walk us through it.
The doctor simply takes a dry cotton swab and gently touches specific areas of the vestibule.
Just a normal touch.
It's just a light touch. And they usually target the areas around the major and minor vestibular glands, specifically the Bartholin and Skene's glands.
And why test those glands specifically?
Because these are the glands responsible for producing lubrication at the vaginal opening. And for reasons researchers are still actively studying, the nerve proliferation, that dense overgrowth of pain fibers, tends to concentrate very heavily around these specific glandular structures.
Wow. So for a patient with this condition, the light touch of a cotton swab on those glands feels like burning acid or being cut with a knife.
Exactly. It's excruciating.
Okay, so they have primary onset and they have severe localized pain on the Q-tip test. The guidelines also state the doctor must exclude all other potential causes before even considering surgery, right?
Yes, exclusion is a huge part of the criteria.
Like what?
Well, they must rigorously rule out active yeast or bacterial infection.
Yeah, that makes sense.
They also have to check for hormonal atrophy, which can happen during menopause, or, surprisingly, even from long-term use of certain birth control pills that can thin the vestibular tissue.
Oh, wow. I didn't realize birth control could do that.
It can, and they must rule out dermatological conditions like lichen sclerosis.
Okay.
Furthermore, the patient must have formally failed conservative non-surgical measures for at least 2 to 4 months.
Okay, so a patient checks every single one of those boxes. But as a surgeon, before you permanently remove tissue, you want absolute proof that the pain is coming exclusively from those overgrown nerves.
You want to be entirely certain, yes.
The San Diego Sexual Medicine Clinic source detailed a diagnostic tool that I just found fascinating: the Marcaine epinephrine nerve block.
It is an incredibly elegant way to isolate the hardware issue.
How does it work?
First, the doctor performs the Q-tip test to establish a baseline pain score. Then they take a numbing agent, usually Marcaine, combined with epinephrine, and inject it directly into the submucosal tissue of the vestibule.
Wait, epinephrine? Like adrenaline? Why are they injecting adrenaline into an area that is already experiencing severe burning pain?
I know it sounds entirely counterintuitive, but epinephrine actually acts as a vasoconstrictor.
Okay, meaning it temporarily shrinks the local blood vessels.
Precisely. It acts like a dam, trapping the Marcaine in that specific localized tissue so it doesn't just get washed away into the bloodstream.
Oh, that is so clever. So it gives the numbing agent time to completely saturate and silence those overgrown nerves.
Exactly. So they place the block, wait about 10 minutes, and repeat the Q-tip test.
And if the pain vanishes completely, you have your definitive proof.
Yes. A positive nerve block test, where the patient feels zero pain upon retesting, proves the pain is localized entirely to those specific vestibular nerves.
That's amazing.
It is. A separate study of the European guidelines actually showed that a positive response to topical lidocaine gel applied prior to penetration is another strong predictor.
So by temporarily unplugging the local system, you prove the hard wiring is the absolute culprit. If numbing the nerve stops the pain, removing the nerves will essentially cure it.
Right.
But there is a massive clinical catch-22 that doctors have to navigate here. We talked about muscle spasm, and we talked about nerve overgrowth. What happens when a patient has both?
This is a crucial point in the guidelines. It is actually incredibly common for a patient with neuroproliferative vestibulodynia to also develop severe vaginismus, which is the involuntary spasm of the pelvic floor.
Well, think about the biological mechanism, right? If you experience severe burning pain every time something touches your vestibule, your pelvic muscles are obviously going to learn to instinctively slam shut to protect you.
Exactly. The software develops a glitch because the hardware is faulty.
The muscle guarding is just a perfectly logical response to the burning skin.
It is a totally protective reflex.
Yeah.
But here is the critical rule. If a patient has both the nerve overgrowth and the muscle spasm, they must undergo downtraining physical therapy to resolve the muscle spasm before they can ever have the vestibulectomy.
See, my initial thought reading that was, why? If the nerves are the root cause making the muscle guard in the first place, why not just cut the nerves out first?
Because surgery on the skin will not fix the muscle spasm beneath it.
It won't.
No. If you perform a vestibulectomy on a patient with active vaginismus, you set them up for a devastating postoperative experience.
How so?
Well, they wake up from surgery, and sure, the skin pain might be gone, but their muscles are still clamped entirely shut. Penetration is still impossible and highly painful.
Oh, I see.
And the psychological blow of undergoing a major surgery and still having pain completely reinforces the brain's fear response, making the muscle spasm even harder to treat later.
That makes perfect sense. You have to fix the software guarding mechanism before you operate on the hardware.
Exactly.
So, assuming the muscle tension is fully resolved and the nerve block confirms the hardware issue, what does the surgery actually look like? What's the contemporary approach?
The modern evidence-based procedure is a complete vestibulectomy with a vaginal advancement flap.
Right, because in the older retrospectives, they mention partial vestibulectomies.
Yes, some surgeons used to just remove the posterior or bottom part of the vestibule.
But that changed.
It did. Subsequent research showed the neuronal overgrowth usually extends throughout the entire vestibule. So the contemporary approach is to completely excise all the affected vestibular tissue, removing a sort of horseshoe shape right around the opening.
But wait, if you remove a complete horseshoe ring of tissue from the opening, you can't just stitch the inner edge directly to the outer edge, right?
No, you can't.
Because that would create a stricture. The opening would become permanently narrower, which basically defeats the whole purpose of the surgery.
That is the exact architectural problem the surgeon faces. and enter the vaginal advancement flap.
Okay, what is that?
To close the gap without creating a stricture, the surgeon goes inside the vagina, gently mobilizes the healthy, stretchy vaginal mucosa, and pulls it down almost like pulling down a sleeve to cover the area where the painful tissue was just removed.
Wow, that completely solves the structural issue.
It does. You are replacing the hypersensitive nerve tissue with normal, healthy, elastic vaginal tissue.
That is brilliant.
And the final, critical step involves anchoring sutures. The surgeon places deep stitches to anchor this new vaginal flap directly to the underlying perineal tissue.
So it stays in place.
Exactly. This secures the flap, preventing it from retracting or tearing during the healing process, and ensures the vaginal opening remains wide and functional.
And when patients are properly selected based on these really strict criteria, the success rates are incredibly high, right? Up to 90% report significant or complete relief.
Yes, the outcomes are fantastic for the right candidates.
Which is truly life-changing for someone who has lived with severe invisible pain for years.
Absolutely life-changing.
So what does this all mean for you listening? If there is one major takeaway from diving into these sources, it's that chronic pelvic pain is not a single generic problem.
Not at all.
It requires intense diagnostic detective work. A clinician has to use the Q-tip test, they have to map out the onset timeline to see if it's primary or secondary, and they have to explicitly feel for muscle guarding.
Because differentiating between a muscle tension issue requiring down training and a nerve density issue requiring surgical excision, well, it's the difference between years of ineffective treatments and finally finding a cure.
It is exactly the difference between treating the symptom and treating the entire system.
Very well said.
Now, as we wrap up, we always like to leave you with a final provocative thought, something to explore on your own that builds on what we've unpacked today.
And the sources brought up a really fascinating concept regarding the nervous system's broader role in chronic pain, specifically a mechanism called central sensitization.
Central sensitization. How does that tie into pelvic pain?
Well, when someone experiences localized pain for a long period of time, say years of unmanaged vestibulodynia, the central nervous system itself becomes highly reactive.
Okay, so it adapts.
Yeah, the brain starts amplifying the threat. It essentially turns up the volume dial on all pain signals coming from the pelvic region.
Wow. So even if the original physical trigger was mild, the brain interprets it as catastrophic.
Yes, the brain is desperately trying to protect the body, but it overreacts and creates a feedback loop of pain.
And this raises a truly provocative question for the future of pain science, right?
It really does. If the brain can learn to amplify pain through central sensitization, can we find targeted ways to unlearn it?
Oh, that's interesting.
Could we eventually develop treatments, perhaps non-invasive neuromodulation or advanced cognitive reprogramming that speak directly to the brain's pain pathways?
Basically, finding a way to update the central operating system so effectively that the brain just stops sounding the alarm.
Right, potentially bypassing the need for months of physical therapy or major surgery altogether.
That is a frontier of medicine that could completely change how we treat not just pelvic pain, but chronic invisible pain anywhere in the human body.
It's a very hopeful thought for the future.
And that is a fantastic thought to end on. Because whether you are dealing with a clearly broken arm on an X-ray, or the microscopic overgrown nerves of the vestibule, the ultimate goal of medicine is always learning how to read the complex signals the body is sending.
And figuring out the smartest, most precise way to answer back.